Jared, talk to us about atezo as well as durvalumab, another PD-L1 inhibitor in non-small cell lung cancer.
So sure, so these are PD-L1 inhibitors with very interestingly named trials. So on the topic of atezolizumab, we start with the tree hugger trials. So we have the Birch trial. So Birch allowed any line of therapy. This was first, second, or third line lung cancer. What was common to these patients were high levels of expression of PD-L1. Our response rates were in the 24 to 27% range, and I can't quote you most of the PFS or OS because they're very happily immature at this point. Most of them are not reached. You get into Poplar, this was a randomized phase 2 of previously treated patients. PD-L1 positive and PD-L1 negative patients were allowed on this trial, but the results were reported separately by PD-L1 status. So in the PD-L1 positive patients, we had a nearly tripling of response rate from 13 to 38%, and we had a doubling of our PFS from 3.9 to 7.8 months. Even in the PD-L1 negative patients, though, you can't disparage that data too much. Response rate was exactly the same, 15% in each group. PFS was 2.7 in 3 months, so basically just about the same. And even survival, 9.7 and 12.6 months, favoring the immunotherapy arm. So, two very different trials in terms of design in which patients are on them, but both inspirational and following the same themes that we discussed in the context of the PD-1 inhibitors.
And then we're all waiting for the large OAK trial, which is the large phase 3. Poplar was phase 2, yes, but OAK is phase 3. I think there are upwards of 1,200 patients on that trial. Again, the comparison, immunotherapy versus our old friend docetaxel, I would predict that that's going to look very similar to what we've seen with the Checkmate and the Keynote trials. Durvalumab, another PD-L1 agent?
Yeah, so in head and neck, we have a series of trials named after birds of prey. The HAWK trial is for cisplatin refractory PD-L1 positive head and neck cancer. So defining lines of therapy is a little harder in head and neck cancer than it is in lung cancer because the default patient is treated for cure. And the default patient who is now incurable has received multiple prior lines of therapy. So the cleanest way to define these populations perhaps is just as cisplatin refractory. So that was a cisplatin refractory PD-L1 positive study of MEDI monotherapy that's ongoing. We have our Condor trial, which is for our PD-L1 negative patients, also platinum refractory. Here we have a 2-to-1-to-1 randomization though, between MEDI-TREMI, so PD-L1 and CTLA-4 inhibition, versus durvalumab alone, versus standard of care chemotherapy. And then we have the EAGLE trial, which is our second-line trial unselected by PD-L1. Again, a 1-to-1-to-1 randomization. And finally, most people haven't heard of this bird, but the Kestrel, also a bird of prey, is the first-line trial which is a 2-to-1-to-1 randomization. The two-arm is durvalumab with tremelimumab. We have a monotherapy PD-L1 arm, and then we have, again, on the theme of toxic chemotherapy regimens, a somewhat toxic regimen called Extreme, platinum 5-FU and cetuximab.
Okay. And, Mark, if I could just mention, Jared was discussing the Birch trial, and one of the things as a lung cancer doc I was very excited about, we're used to response rates always dropping as you got into first line, then second line, and third. And if you're thinking about chemotherapy, your response rates drop 20 to 30, down to less than 10% in the second line. By the time you're in third line, you're down to 1%. I mean, when you looked at the second and third line responses to immunotherapy,
mid 20% range.
Right. Yeah. So in other words, second, third line patients are responding to immunotherapy just about as well as first line patients.
Yeah. One of the themes that we've seen, and John addressed this earlier, was that there seems to be similar activity between PD-1, PD-L1 agents across all different tumor types, and the observation that whether you get it first, second, or third line seems to be pretty consistent. One of the agents that we've talked about, I didn't get a read on the data in bladder cancer, is durvalumab. Do you have any data there that would be notable?
We do, and actually FDA got the data and made it a breakthrough designation in February, and so that's being presented at the meetings. Durvalumab is clearly active in patients who are PD-L1 positive. The response rate was just over 50% in previously treated patients. That's a pretty high number. It's a small number of patients. Actually, it was a 61-patient trial. We have the data for 42. We'll get more data during this meeting. But it certainly proves the point that it's active. I was listening to John talk about MYSTIC, and the next study is exactly the same thing. I guess you're following melanoma, and we're following you, because it's durvalumab versus durvalumab plus tremi versus standard of care chemotherapy for first line, 1-to-1 randomization for first line therapy. And the chemotherapy is basically a platinum-based chemotherapy, which is standard of care. And we should get a readout. I can tell you the accrual to these trials are getting very rapid. It may not be where melanoma and renal was a little while ago, but I think we're getting there.
Yeah, we've had waiting lists for these studies.
Yeah, and that actually brings up the next.